this evening's speaker is Clare Bankhead, who is from the Nuffield Department of Primary Care Health Sciences at the University of Oxford, and she's also a fellow of Kellogg College. So over to you, Clare.
Thank you very much, Simon. Well, first of all, thank you very much for inviting me this evening to talk. I'm delighted to be here in person. I'm delighted to see you here in person, and I'm slightly trepidatious about the people at home. As Simon said, I'm Clare Bankhead, and I work in the Nuffield Department of Primary Care Health Sciences here in Oxford. It's just across the road in the predominantly glass building with the Triton fountain, so that's where we can be found. I'm an epidemiologist by training, but not of infectious diseases. And my research focuses on the use and the role of primary care generally. And when I'm talking about primary care, it's the first point of contact for most people when they're accessing the health service. So when you go and see your general practitioner, your GP, that's what I'm going to be primarily talking about today, those sort of encounters in general practice. My research interests are in the early diagnosis and detection of cancer, monitoring and treatment for long-term conditions, and primarily using routinely collected healthcare data to address a variety of clinical questions. I head up a wonderful small group of researchers and data scientists who all use routinely collected healthcare data, and I'll be peppering my talk with examples of all of our work as I go on. Okay, so just to give you a bit of background, at most healthcare encounters in the UK, data are collected and stored in electronic healthcare records. And this occurs in GP practices, in hospitals, and there are also some national registries, which include the National Death Register and the National Cancer Registry. And some of that data is available in anonymised form for research. And that is what I will be focusing on now. So what is big data? Well, the sort of data that I'm going to be talking about today, it includes thousands of observations on millions of people over decades of years. So that's what we're talking about. And there's been this conceptualization of big data about the V's of big data, and it is generally accepted that there are at least 3 V's of big data: volume, variety, and velocity. There's also this one with an additional 4th element of veracity, so how reliable is the data. And there are various models about the V's, and there's even one that goes up to 10 V's, but to my mind, I think that's pushing it a little bit too far. So I'm going to primarily talking today about the 3 and 4 V models. Okay, so thinking about that first V of volume, this is what the main sources of primary care data. And when I was putting this slide together, I suddenly realised that they all use blue for their logo. So I'm sorry it's a little bit monochrome, but I'll tell you about each of these. So the ones that I'm most familiar with is I use CPRD, which is the Clinical Practice Research Data Link. I use that one the most in my research, and Orchid, the next one down. But CPRD itself comes in 2 flavours. One is called Gold, and that currently has just over 3 million active patients in that data. So those are people who are registered in primary care and are alive currently, and they are mostly from Wales. There's another flavour of Aurum, of CPRD data called Aurum, and that includes 41 million historic records. So that includes people who have died, who've moved away, and also practices that were in the data and have no longer contributing to it. And that equates to 13.4 million active people in that data, and that's predominantly based in England. Now, Orchid is also predominantly based in England, and it covers 18 million people currently. And this one's a little bit different to the others because it draws on 3 different electronic healthcare record providers. That's EHR, it's electronic healthcare record providers. So that's essentially the commercial companies that provide the IT infrastructure that the GPs enter the data into. And they're all slightly different, and the data comes in different formats. But within Orchid, they are harmonised so that they can all be used together. Now, Open Safely, really exciting one. Based in Oxford, Orchid is based in Oxford, Open Safely is based in Oxford, and so is Q Research, which I'll come to in a minute. But Open Safely, new kid on the block. It started in March 2020 when the pandemic kicked off, and it was a huge concerted effort. And it includes 58 million people in this country from 2 electronic healthcare record providers. And at the moment, those data are treated separately. So most of the research that's been published from that has been on one of the healthcare providers or the other one. And at the moment, Open Safely is only available to do COVID-related research. The other databases have no restrictions on that. Q Research, as I said, is in Oxford as well, and that currently has just over 13 million active people in the data and 35 million historically. And that's from one electronic healthcare provider. Research One is from a different electronic healthcare provider, and they have 50 million historic records, but I couldn't find how many are currently active. But that's what that one is. And then finally, Thin, it incorporates 5 to 6% of the population, so approximately 3 to 4 million. So that's where you can get data from. Okay, so that's an idea about the volume of what we're talking about. So this is some research that we did several years ago now, and we did it in CPRD Gold, which was the smaller data offering. And so this is just to give you an idea of what the scale was then. So this is looking at data from only 398 practices, because all of this has exploded really since COVID. All of the databases have increased in size. But this time, this one had data from 398 practices, and we looked at all the consultation records within that data for an 8-year period between 2007 and 2014. And it was 102 million nurse and GP consultations. And this is the infographic saying on average, people attended their general practice about 5 times per year. Obviously, there was huge variation according to age and gender. But nowadays, that's 102 million consultations over an 8-year period. Now the size of these data sets, we're looking at 80 million consultations in a single year. So that's an indication of how much bigger this has got. But getting back to that other research from 2007 to 14, what did we see? We've seen, because in the press, it's always been reported that GP practices and doctors are under immense pressure. And this was still the case back when we were doing this in 2015. And we wanted to see whether that was a perceived pressure or whether it was actually a real pressure. And we identified that it was a real pressure, and that there'd been a 16% increase in consultations over that 8-year period. And not only had the consultation rates increased, but also the duration of them had also increased from 8.5 minutes to 9 and a bit minutes. Not a lot of increase, but when you add them all up, that's a lot more contact time that GPs were having. Now, one thing that I thought was interesting when I was looking back at this slide is that at those times, the phone consultation rates doubled from 2007 to 2014, but the majority of consultations, 90% of them, were still face-to-face. And of course, that all changed in March 2020 as well, when we had almost overnight switching to remote consultations. So it was a complete switch, and they were scrabbling around working out what to do. Patients were scrabbling around what to do. And that was the situation then. We are getting a return now to more face-to-face consultations, but actually some of the good things about being able to consult remotely, I think, will stay. But we'll see how that's changed in later time. So what about the variety, the second V? I'm going to tell you more about the clinical practice research data link. And this data is refreshed every month. And so in the March data offering, you always get this data, what is included, what is the variety of the data here. So in the core data, you get details about the patient, so you know their age and their gender, and you know how long they've been registered in that practice for. And you get information about the consultations and what happens in those consultations and who they were with a GP or a nurse. And you get details about the practice as well. So the practice postcode and information like that. And within this, you have all the coded information and coded information, it's important to say. So the things that when a GP is typing in free text, we don't get that data as researchers because that is very hard to make anonymous because, well, it's just very hard to do. So we only get the coded data, but we get the coded data about any diagnoses, any prescriptions issued, referrals made, tests that were done and their results, and immunisations. So that's the primary care data. So imagine you've gone to your GP recently, that coded information is there if they're contributing data to one of these data resources. And you as patients should know that actually, because there should be a privacy notice in the GP practice saying that that practice is contributing data to, and it should name the resource. And so you should be able to see whether your records are included in one of these. But I will reassure you they are anonymised. So as researchers, we don't know. So that's the primary care data, but there's a whole variety of other data that can be linked to it. You can link to deprivation data, and you can do that on the basis of the practice level deprivation, or you can get it at, they call it patient level, but it's not really patient level, it's at a lower level data, so a few streets. So we don't actually get the postcodes of the people, but we get their deprivation indices. You can link it to mortality data, so you can find the dates and causes of deaths. And we can link it to hospital data, and that's inpatient episodes, so when you stay overnight, accident and emergency data, and outpatient clinics as well. So all that data is available and is linkable. Patient-reported outcome measures. That's a very small little subgroup, which is available for a few years of data, and it's mainly about patient-reported outcomes after they've had joint replacement therapy, surgery, and hernia repairs. So a little bit niche, that one. Now, this is something that is unique to CPRD. The mother, baby link and pregnancy register is actually quite hard to identify pregnancies within medical records data, or at least the start and end of them, because women don't go right at the beginning of their pregnancy, they go for their booking appointment at sort of 9 to 12 weeks typically, and not all pregnancies end in a live birth. So CPRD Central, based in London, have done an algorithmic approach to identifying starts and ends of pregnancies. And then linked to that, you've actually got a mother-baby link. So you can see, you can look at the mother's record and the baby's record and look at that combined health story and journey. And so that's incredibly useful for some research questions. There is also linked to some mental health data, but that is for serious mental illness that results in inpatient episodes. So again, quite niche, and I haven't used the mental health registry at all. The other thing you can link to is the cancer registry. So all cancers registered in England, and you get information about where in the body that cancer was and the stage and grade of it, so how bad was the cancer when it was diagnosed. And then there's also information about the chemotherapy regimes, radiotherapy regimes, and then there's a smaller subset about patient experiences of cancer. And then lastly, there is a diagnostic imaging database, which sounds really, really exciting, but actually you don't get the images. You get coded information of what the images showed. So again, we as a group haven't looked at that data very much. We thought we might, but it's limited, but we do have access to it. Oh, and a point to note that actually the University of Oxford has got a site license for using this data for research. So if anybody's interested in doing research using this data, then please do contact me about it. Okay, so I've already told you the sort of headline figures about how big these practices were, but just for completeness, the two data flavours, gold includes nearly 30 million people over time, of which only 3 million of those are currently active. But by far the biggest version of CPRD is that all-in one, which I mentioned earlier. But look, you see, you can go back to 41 million people in the data. And as I said, it spans decades. The quality of the data is really quite good from mid-90s. Okay, a little bit more about Orchid. And the reason I wanted to tell you more about this one is because it ties in with that third V of velocity. How quickly does the data refresh? And I said most of these other databases are refreshed monthly. This one was set up over 50 years ago, actually, to do flu surveillance specifically. So every flu season, they actually do virological swabbing of patients who come in with influenza-like illness so that they can track what strains of flu are circulating in the population. And no surprise, it rapidly expanded in 2020 and did lots of COVID surveillance, and it still is. It's still COVID swabbing. So, you know, there are some benefits that we've seen in the last couple of years. But here, as I said, this is the only one that includes more than one type of electronic healthcare records represented by the different coloured dots. And it's got pretty good national representation. But what I really wanted to point out to you from this slide is that they have daily and weekly uploads of data for the purposes of surveillance. For our research purposes, we tend to just go with when we need it. But we will be doing more formal refreshing of that as we go along, and it will be monthly refreshed. Okay. So that covers the introduction and the landscape of what I'm talking about, really. And if I remind you of what the title of the talk was, it was Big Data Computing in Healthcare, Opportunities, Obstacles and Outputs. So I'm now going to start talking about the opportunities that this data affords us, and I'm going to illustrate it with some of the outputs as we go along. So the first one, the data's there. It's already recorded, and I've put an asterisk because that's also an obstacle, which I'll talk about in a moment. But for now, it's a great opportunity. The data is there and it's large, so you can be quite confident in your results. It's been shown most of the data offerings, they've all done this sort of analysis. They're broadly representative of the population. And this is the one from CPRD Aurum, which is the one I've said that I'm personally most familiar with. And this is the population pyramid of the age and gender breakdown of the Aurum database, which is the white bits, and the national situation in England. And both of these were mid-2017. So you'll see they're broadly similar, although Aurum has a few more people in the young to middle-aged adults. Okay, now because it is so large. It's an ideal environment to do research on uncommon diseases. I was going to say rare diseases, but when I presented this to my group, they went, oh, you've got to be really careful because they might be saying, what's the definition of a rare disease? So I'm just going to go with uncommon diseases and rare outcomes. I have gone for rare outcomes. And you won't be surprised, including drug, vaccine, side effects. So let's see what's been done on vaccine side effects. So this was a collaborative analysis of 3 different data sources, one from England, which was drawn from the Orchid network, one from Wales, which is called SAIL, and a Scottish data as well. So they each analysed their data separately and identified these cases and then put them together. And what this is showing you, maybe I'll point with my pointer. So they were looking, and I don't know, in the press, there was a lot of anecdotal reporting of unusual side effects associated with COVID vaccination. And one of those was a rare blood clot in the brain, which is called, what is it called? Cerebral venous sinus thrombosis, CVST. And so anecdotal evidence, what's the real evidence? So this analysis was done to look at the occurrence of that rare blood clot on the brain after vaccination. So this top bit of the table is looking at the Oxford AstraZeneca vaccine, and the bottom half is looking at the Pfizer vaccine. And what they did is they looked at all the events that had occurred in the period before vaccination and in the period around vaccination and after vaccination. And this is what they found. So this one here is a reference. So essentially, if you've got a value here that is greater than 1, that shows an increased risk. And for the Oxford AstraZeneca vaccine, there did appear to be an increased risk, almost doubling increased risk. Although a doubling risk of a very rare event is still very rare, okay? But it was statistically significant. As you can see, that's shown here by these confidence intervals, and the lower level of the confidence interval is still above 1. So that's what shows us that it's statistically an increased risk. So that was shown for the Oxford AstraZeneca vaccine, but it wasn't evident for the Pfizer vaccine. And that was partly the reason that the MHRA, the Medicines Regulatory Authority, decided to give younger people the Pfizer vaccine rather than the AstraZeneca. So that's an example of how this data has been used to examine rare events. So another opportunity is the speed of the research. Obviously, it's there. Again, with the same asterisk to remind me to tell you about the disbenefit of that. But this sort of rapid epidemiology compared to the more traditional epidemiology. So if you were to do a study from the start without using these pre-existing data resources, you would have to go out and recruit the people that you're going to be studying. Now that takes time in the recruiting. Okay. You then have to do the measurements on those people of what their exposures are and any potential outcomes. Okay. You do that at the beginning of your study, and then you follow them up for some period of time and do it again. So you can see how this takes time. You've got to recruit them, and then you have to follow them up. And that all takes time. Whereas when you have this data here, you can look back at it, and it spans decades. So it's rapid. What do I mean by rapid? Well, I'm sorry, it's another COVID example. But what I wanted to show you here, this was the first paper that came out of the UK about COVID-related death and the risk factors for it. And what I wanted to highlight to you here is this paper was received by the journal Nature on the 15th of May, 2020. When we went into national lockdown on the 23rd of March. So 6 weeks after we went into national lockdown, this analysis had already been done and reported. And then it took the journal about the same length of time to actually publish it. But that is rapid research. And admittedly, all efforts were put into it. People were working night and day to get this done, but it was possible and it was done, and it was very exciting. And this is just the top half of one of their results tables, which showed us for the first time that the elderly were at much increased risk. Here, this risk of dying. This red dotted line is sort of like equivalence, no extra risk of dying if you're along that red line. But you can see that with age, that risk really increased. And that's why we shielded many of our elderly population. And the males were more likely to die, as there was a trend with obesity, non-white ethnicity had higher risks, and that trend with deprivation as well. So really exciting stuff that came out at the beginning of the pandemic. So another opportunity that this data gives us, it's really good for looking at the real world evaluation of interventions from trials, because trials of, say, new medications, they're done in quite selected groups of people. And like the epidemiology that I said earlier, you have to identify people who are suitable for your trial, who have the clinical condition that you're interested in. Then you give them the medication. For how long? Do they take it, maybe it's only a week's treatment. If it's antibiotics, a week of antibiotics and an antibiotic. It may be a year's treatment if it's a longer term chronic condition, and you follow them up. So it all takes time. But then that drug goes to market. And so it's been done for however long each individual was in the trial. Let's say, for the sake of argument, they were in that trial on the medication for a year. Trial gets approved and marketed. But then the people that it's prescribed to, if it's a long-term condition, there'll be long-term users of those drugs. And that's not seen in the trials. So this is when this data is really good for looking at the real world effects for longer term conditions, and also rare late effects of treatment. Side effects are often identified in this sort of way. Also, trials, as I said, often done on quite a sort of homogenous group of people. They tend to be the less elderly. They tend to not have so many chronic or comorbidities, not so many diseases all at the same time. But again, once that drug is used in real life, it's given to people like us, people like our parents, who may be having more than one condition at a time. And so therefore, this is what you can see, what happens in real life when these drugs are out there in the wild, as it were. Okay, so other opportunities. It's really good for looking at interruptions or alterations to anything. And some examples I've given here, interruptions to services, such as clinical provision, interruptions to the natural order of things, so disasters, not so much in this country, but after earthquakes, what are the longer term health impacts of earthquakes, but also like extreme weather at a time, particularly hot spell can be associated with more mortality, particularly in older people. But it's also very good for looking at progressive changes. An example given here is climate and health, and I've got colleagues who are looking at that now and the longer term. But obviously, what has been the most disruptive thing to the health services? Well, I'm sorry, again, it's COVID. But this is some work that we did looking at consultations in primary care in the 2 years before COVID ever came. So from 2018 up to the end of 2020, that's when our data stopped on this particular set of analyses. And what I'm showing here, this is consultation rates by week for breast lump on the top row and change in bowel habits, those cancer focus this is. And what you can see is at the start of the first lockdown, there was a dropping off of consultations. That's of all sorts, because remember the phone ones are still logged. So people consulting on the phone, they're still being logged, but there was that big drop off. And look, change in bowel habit dropped off enormously. It almost went down to 0. But then as we sort of got used to living with COVID towards the end of the year, these consultation rates started to pick up and had more or less come back to where they were before the pandemic. These next two plots, this one here shows the cumulative number of consultations by week compared for years on years, with the darker dots being the COVID year. So here we go, we're going along till March and then suddenly it plateaus with nobody consulting, picking up. And this third plot is about the referrals. So you've been to your GP and then they refer you on for specialist opinion. What happened to those? And again, there's a falling off. And in fact, we saw that we went backwards for about 2 years worth of data because referrals have been increasing in 2019, but they dropped back down to 2018 levels. And we're just looking at some data now to see whether that has impacted on cancer diagnoses as well and stage of diagnosis. So has there been a delay? We'll report on that shortly. This is the same plot, but for a different symptom. And I just thought I'd show you this one because it's really interesting. This top one is cough. So you can see here, we've got a seasonal variation of cough. They occur more in the winter. So no surprise there, up and down, lockdown, suddenly nobody had coughs. Of course, everybody had coughs, or quite a lot of people had coughs, but they weren't consulting about them. And the referrals for suspected lung cancer had not recovered by this time at all. And so this information is actually helping Cancer Research UK to formulate their public awareness campaigns that sort of get back to health message. And so we're feeding back to them quite regularly on our analyses. So what are some other opportunities? This one here, I've put the Orchid logo here because the Orchid data offering is the best one for doing this sort of thing. And what I'm talking about here, I'm talking about, say, more bespoke projects. So we've got some projects in underway looking at chronic kidney disease, for example. And we actually recruited people from GP practices around Oxfordshire who are living with chronic kidney disease, and we brought them in at 6-monthly intervals to do measurements on them. So that was a sort of like quite intensive study for those patients to come in and have their measurements done. And we did that for a period of 2 years. So each person was in the study for 2 years. And we're now doing long-term follow-up of those same people, but linking to their medical records with their permission in this case, because it is identified as that information that we've got, because we've recruited those people and they've consented for us to do that. But you can do that in this Orchid data set. And so without any extra burden to those participants, we're not asking them anymore to come in. We are just harvesting that information from their medical records. And so it's happy for the patients and has a lower cost than actually calling them in, both in terms of financial cost, but also time. Of course, these things aren't free. Nothing's ever free. There are costs. Okay. So another opportunity, the methods, the analytics that have been happening. So there's a huge increase in the amount of machine learning and AI. It's a real buzzword, AI in healthcare. AI, hashtag over there. So yeah, but there's issues with artificial intelligence and machine learning. It's not necessarily explainable and understandable. And what is it doing? Sometimes we know, sometimes we don't know. And I'm just putting a flag out here for a debate, which is going to be a public debate. It is going to be part of a new MSc then, starting up in October in Applied Digital Health. But this debate will be a public event, and it's between a machine learning professor and a professor of medical statistics, and they're going to argue which approach is best for clinical prediction. So I will keep you updated as to when that's going to happen, but it's the second week in November. Okay, I'm coming back now to these V's, and I'm moving on really to the obstacles, really. And I'm going to focus on this veracity, the uncertainty of the data. So what are the problems that, that we face when we're looking at this? Now, this is a quote that my colleague, Sarah Leigh Flurry, who has moved on from academia to industry, but she found this quote and it really is resonant. It was said by Peter Lucas, who worked at Bletchley Park in the Second World War, decoding German messages as part of the code busting. And he said, it was not a matter of receiving straightforward messages and translating them. It was a matter of receiving material which was nearly always more or less imperfect, often incomplete, rarely intelligible with ease, and at its worst, totally meaningless even to the best German scholar. So you go, okay, why does that have resonance? Well, let's break it down. Routine healthcare data is more or less imperfect because it's not collected for research purposes. That's why I kept having that asterisk about when I said it's readily available, it's already there, it's being collected, but it hasn't been collected for the purposes of research. So as a researcher, you have no control over what is being collected, when it's being collected, how, or in whom. Okay. And it says here that the recording of this information is influenced by incentives. So in the UK, one way that GPs get paid, there's a thing called quality outcomes framework. And for certain clinical conditions, GPs get paid for maintaining registers. So an example is asthma. They get paid for maintaining a register of all their patients with asthma. And then for those patients, they are meant to do at least annually peak flow measurements, so to measure their lung function. And if they get a certain proportion of those people on the register with a valid peak flow in that year, they get paid. And so, and the only way that you can tell if those activities are being done is if they're coded. So for some conditions and behaviours or tests or whatever, that data is really well coded because their pay depends on it. So you can use it to your advantage as a researcher. You go, oh, it's quaffable. Often incomplete. Well, it's recorded for service users only. So obviously the data's only there if you go to your doctor. Rarely intelligible with ease. And Sarah ascribed that to errors in recording with common. I also think that actually the data is, because it's not recorded in a standardized way, you have to look harder for things. An example that I can give you is, say you're looking for people with high blood pressure. There are diagnostic codes for hypertension. So you could select out all the people with those diagnostic codes and go, there you are, I've got all my people with hypertension. What if the GP didn't actually put the code in, but it's in the free text? Yeah. And so it's fine for clinical care because the information is still there in the medical record, but it's not there in the codes. So then you might actually want to look at blood pressure measurements themselves and look for evidence of high blood pressure. So then you're starting looking through all those test results. Or you may think, actually, it's important for me to look at whether there are prescribed antihypertensive treatment. So that's a rarely intelligible with ease. You've got to really sort of look for the data and you need to be able to understand it. So it's important to work with people who understand the data as well. And at its worst, totally meaningless. So yeah, there's some data that is so implausible that it can't be used to research. So evidence of a live birth in an elderly woman probably isn't plausible. But so again, you just have to go into this with your eyes open and know what you're dealing with. Okay, so I've mentioned that it's not recorded for the purpose of research, and you'll probably gather that's one of my bear bugs that for me, that's the most important obstacle. But is it fit for purpose? Yes, it is. I think it is generally. But as I say, you have to go in with your eyes open and you need to think, is it biased in terms of who's included in the data? Does it include this gentleman here who is begging on the streets? Is he homeless? Is he registered with a GP practice? So, you know, people like him may not be included in the data. And I got this picture from a website, Unsplash, and the photographer, Nick Fewings, put some words about this because when I was deciding to use it, you can use them, they're royalty free, so it's fine. But I thought, actually, you can see that person there. Is this okay to use this picture? But the photographer put some information about it and said, after taking this picture, he actually went to speak to that man and he bought him a meal and bought him some dog food for, there was actually 2 dogs in that picture, and one snuggled up under the blanket. And so I felt reassured about using that picture. So that's in terms of who's in the data, but also what things are recorded in the data. So picture here is somebody standing on a weighing scale. Now there's some evidence that weight is recorded more frequently if there's a clinical concern. So it's more likely to be recorded in those that appear to be underweight and then people who are overweight or obese, because then you can encourage weight loss. Also more recorded in pregnant women. So just be aware, really. There are health checks. So when you reach the age of 40, you're invited for a health check. And weight is partly one of those. If you register as a new patient, they weigh you as well. So data is getting better, but it may not be there. And it may not be there when you want it. If you were doing a study about weight at age 20 and what's the impact of that on future dementia, I made that up entirely, by the way, but weight at age 20 is unlikely to be recorded at that point. So then you have to make some assumptions and go, okay, I'm going to be flexible. Is it sort of early adulthood weight or whatever? So, okay, and missing data. So one of the largest bits of missing data is about ethnicity, and about 20% of people don't have a recorded ethnicity in their record. But actually, if you look at the data, the distribution of Black, Asian, mixed and other in the data are about the same as the national data. So it looks like it's the white population that have their ethnicities missing. Okay, so 20% of the population in the data don't have an ethnicity recorded. But if you look at the proportions in the data that are Black, Asian, mixed or other, they match quite well to the national breakdown. So you could assume, possibly, that those with missing are likely to be white because the other ethnicities are represented to the same amount as the national data. That data is getting better again. And in fact, hospital data has ethnicity recorded much better. So if you're doing a study where you're using linked data, we tend to use the ethnic breakdown from the hospital data to augment the primary care data. So there are ways of doing this. Okay, what other obstacles? Not recorded uniformly. I've already mentioned that weight at age 20 may not be there. But one of the other things in that the V's was in the variety. Is it structured? Yes, it's structured a bit. The prescriptions are all coded together, so that's helpful. Is it unstructured? Yes, yes, it is. And I've put a comment here that GPs, particularly, so primary care, have a greater choice of codes to use. And I'll give examples of that in a minute. But hospital data is better recorded. There's fewer codes. But again, that's another obstacle which I'll go to in a second. Data not recorded at standardized time points. Said that already, so not at age 20, 40, 60. So I actually had an email from one of the members of the BCS who unfortunately can't be here tonight. So he emailed me and he said, I've got an issue. I've got an issue. He said, with your first sentence of the abstract. This is terrible. The first sentence of my abstract was, in all healthcare encounters, data is recorded and coded electronically. And this person emailed me and said, right, okay, I agree that happens in primary care, but when I go to the hospital, there's a paper notes that are an inch thick. The doctor writes on a clean piece of paper that they put on the front. So what happens to that data? And I said, thank you very much. That's a really valid point, and I hadn't got it in my talk at this point, so I popped it in at 5 o'clock today. So, secondary care hospital data, a lot of it is still paper-based, surprisingly. I think that varies according to what type of clinic you go to, but a lot of it is paper-based. And then what happens is it gets transported often to the bowels of the building, and it's coded by medical clerks, and they code that data. But really, really bizarrely, outpatient data, they don't have to put in what the diagnosis is. So the outpatient data doesn't necessarily contain what the problem is. Yikes. However, procedures and hospital stays are well recorded. So you know if somebody's had a hip replacement, that's coded. And there's a narrow range of codes that they can use to code that. In hospital prescriptions for research, not available. Don't know where they go. Maybe other companies have access to them, but certainly in the data resources that we use, that data just isn't there. So that's definitely not possible. Okay. Data management, pre-processing. People often say, the data's there, it's quick. Can I do it for my MSc dissertation? No, generally not. Not for your dissertation, maybe an MSc thesis if you're doing it by research, possibly. But this data management and pre-processing, it's often unrecognised because people just say, can I just do this? No, it's not a case of just, it's really quite skilled to be able to do this. Because the data comes in looking a bit like this. And when I first started working with this data, this was an actual bottle of wine that I was sharing with my husband. And it was on the kitchen table and I looked and I thought, oh my God, that's how I feel. There's my eyes going, what is this data? This is really scary, this tangled mass that we've got to work our way through. And it's been said by myself and many others that 80% of the time and effort is in wrangling this data into an analysable format to get it into this thing where you can actually see who's in the data, what conditions do they have, and then you can press go on the analysis. It also needs a multidisciplinary team. You can't do this alone because you need to be able to understand the data. You need to be able to work with clinicians who know what this means. You need to be able to work with the data scientists, the programmers, and the epidemiologists who've got the research questions nailed. But actually, that's probably an opportunity and not an obstacle working together. Okay, I've said about codes, I've sort of alluded to them a bit. Because this data is coded, you need to curate those codes. And that's all part of that pre-processing part. And a project that I'm involved in at the moment is looking at Down syndrome in babies. And one of my colleagues said, well, surely there's only one code for that. You must be able to find it. Actually, it's not too bad. There's only 14 that I'm aware of. But for example, cancer research, a colleague of mine in Exeter, he published a paper on cancer and he used a code list of 2,120 codes to identify cancer in the primary care records. Okay, it's not a small task and you need to know what you're doing. But finding 2,120 codes in a coded system that is dynamic, actually, it's changing, it changes all the time, that's not scalable. You can't do that. And my purist side of me, the epidemiologist in me, we do really careful curation. But that's on sort of like individual projects. But if you want to make this scalable, then you need to have a trade-off and you just be a bit more gung-ho about it. But the point is, be transparent, publish the codes that you've used so that other people can look and decide whether they think it's a valid thing to do or not. Okay, other obstacles. I don't know if you've heard of this. It's a very confusing acronym because it's the GPDPR, not to be confused with the other one. I've now confused myself that. But this stands for General Practice Data for Policy and Research. And it was another of the government's initiatives to harvest everybody's medical records on a daily basis and they were going to take the data from primary care every day and put it somewhere that hadn't been said what it's for, and it was going to be used for policy, that's fine, and research, but also it could be for commercial companies. And I appreciate we have to have commercial interests, but it has to be carefully reported and logged. And this was being quietly introduced, and then suddenly people became aware of it. So the government put it off. They were going to be doing it in July 2021. They said in about June last year, I think they said, oh, we won't do it. We won't do it until September. But they still haven't got it all sorted. The public are still not happy. And at the moment, there's no date for it at all. Okay, because they said they need to get everything in order before they'll do it. But they will do it. But hopefully it'll be carefully managed and done in a safe way. Which brings me on to the 5 safes. And this is the overarching thing that we work within. 5 safes are safe data. So assuring that that data is anonymized, or at least de-identified for some purposes, but anonymized data. Ensuring that the projects are good, will answer an actual research question that is needed to be answered. So before you can use these data, you have to apply to the data controllers to use it and submit a full protocol, which will be independently scientifically reviewed before you're allowed to do these things. The researchers, the people using the data, they have to be trained and accredited to do this research. Safe settings, you have to show that the data is secure. And there's different ways actually that you can access data. Some of the data offerings, they will give you a data cut. So if you were doing a study on people with diabetes, for example, you can request for a data cut on people with diabetes and they will give it to you and you can analyze it wherever you are. There's other ways that you can go into the data, into the safe havens, the trusted research environments, and Orchid and OpenSafe here, both examples of trusted research environments. So no data leaves those environments, but you as a researcher or analyst go in and run your code in that environment. And then only the outputs that you get have to be authorized before you can get them out, primarily to make sure that you suppress small numbers so that there isn't an accidental risk of identifying people, particularly with, say, rare conditions. So that's the 5 safes. And I'm just going to finish up by giving you some examples, some other research that I haven't already talked about that we've done. And this isn't exhaustive by any means, so apologies to any of my colleagues who I haven't given a shout out to. But we have published research using this type of data to look at how data is used, I mean, how consultations and the services are used, and whether changes in medication have any impact on consultation status. We also have had a whole suite of research looking at kidney research, and this is one of the slides where you try to put a whole study result on one slide. And but just to talk you through it, we showed that in data from 1.4 million people, that top colouring is the breakdown by body weight. So only 3 in 10, 30% of people are at their ideal weight or below. 4 out of 10 overweight, 2 are obese, and 1 in 10 are severely obese. So that was the population data in 2000. Sorry. And then we showed that actually the risk of severe kidney disease was associated with obesity, and it had a dose-response relationship. So as the body mass index went up, the risk of severe kidney disease also went up. And that was regardless of if you had diabetes or uncontrolled high blood pressure. So other things looked at sort of clinical prediction type studies looking at long blood pressure variability and whether that is a risk factor for cardiovascular diseases, heart attacks, strokes. We also looked at risk factors. So this was the last pandemic. We looked at risk factors for complications amongst children in the last flu pandemic. Again, prediction models of colorectal cancer, and this was using machine learning that had been developed by an Israeli company, and they came and analysed the data. And as an example of, they weren't allowed to access the data, so they had to come and sit in my office, and I had to chaperone them while they were running their model, because they wouldn't release the model to me to run it because it was secret, and I wouldn't release the data to them. So we we literally sat side by side and did that. And then there's some other sort of studies that we've done in cardiovascular disease and diabetes. And I'm just going to finish up with this one. This was a study looking at routinely collected full blood count. So when a blood test is taken, this was looking to see whether there was any indication in the blood biomarkers for a particular cancer called multiple myeloma. And what the data showed here was that the red line are people who had multiple myeloma, and the blue line are people that didn't. And they looked at the blood marker trajectories up 5 years before diagnosis. And you can see here that actually it started diverging with this particular one. The erythrocyte sedimentation rate, ESR, is much easier to say, started increasing in those that had cancer before they were diagnosed. And also plasma viscosity increased as well, but there was no evidence of this one. And so what the analysts concluded from this, hemoglobin measures also decreased in the cases, and they concluded that using a routinely collected blood test could be a sensible rule out test for multiple myeloma. So essentially what that means is, if you had this blood test taken and your ESR was normal, your plasma viscosity was normal, and your hemoglobin levels were normal, then you'd be pretty sure that person doesn't have multiple myeloma. And so you can reassure the patient just from a single blood test in primary care. So that was the application of that one. So I said the data comes in a big tangled mess. You work very hard to get it into a format that you can analyze, and then you finally get your outputs that you publish, hopefully in a high impact journal. And that comes to the end of my talk. I'd like to thank you all for coming. And these are the people that I interact with on a daily basis. There are some notable absences because they didn't have their pictures on the web. But these are the people that I work with regularly. So if you see any of us wandering around in Oxford, please do say hello. Thank you very much.
Thank you very much, Claire. And I've been longing to do that for 2 years, is to applaud a speaker in person. One of the things you most miss when you have online meetings, but that was great and deserved the applause that I've been saving up for you. Thank you very much. Now, Claire's kindly agreed to take questions. For those of you in the audience, I will take raised hands. For those of you online, please can you use the Q&A function in Zoom to type in questions, and we'll pick them up from there. And we'll try and establish a balance between the ones coming in online and the ones from the live audience. If I'll start with the live audience to give the online people a chance to get going. So I'll take a question from live.
Sure, thank you. Amazing presentation here. It was really good. Thank you.
Thank you.
My question is about wearables, specifically about Oura Ring, Whoop, or insect tracker that you would have in the United States. Those would give you all of the data and would track it for you to have it for future purpose and for immediate therapy changes. If X therapy is working better than the other one. Isn't what we need, rather than big data, more wearables? And is there any difference between them?
Really good question. Well, yes, there's definitely a difference between them, because a wearable certainly can give you lots of information. I mean, Apple Watches, how many people here wearing those tell you all sorts of things about your heart rate, your blood pressure, everything, and that can all be used. And in fact, there are people that are looking at enhancing medical records with wearable technology. They're also very good as well for, you know, the sort of blood glucose measurement, those sort of implantable stroke wearable devices. I think my personal view is that they have different purposes, and I think you would get an even more biased group of people if you restrict wearables. But I think that's definitely a way to go. And other colleagues of mine do much more about wearables than me.
Thank you. Do we have an online question?
Yeah, we've got a few questions. There's a question from Bruce Bennett. You mentioned missing data, but I wonder if you could comment on data sparsity. The old absence of data evidence is not evidence of the absence of issue.
Yep. Very good question also. Yes, absence of evidence, so the code isn't there. Is that evidence of absence? Sometimes I would argue that it is, because I think if you have diabetes, for example, there will be a code in your medical record somewhere, or at least evidence that you're on diabetic medication. So I think it could be argued that in some cases you can assume that, and we often do that. Regarding the sparsity of data, yeah, I mean, that's tricky, because what do you do? Do you take the last value carried forward? And how sparse is sparse? You know, I mean, sometimes things are not measured for years. So for some things like maybe adult height, you'd be willing to accept more sparse data on that, because you generally maintain your adult height until you get older, and then you start dropping off. So, you know, you could assume that your height at age 25 is going to remain the same until you get to 60, 65. But yeah, really, what do you do with missing data? How do you impute it? What do you do? And there's various different methods for imputing data. So we frequently use multiple imputation as one of the methods for filling in missing data. But that isn't perfect. But it's a whole methodological paradigm on what to do with sparse data.
We've got another one here. Dean. Dean is asking, Claire, do you think you will need to migrate your research capability when GPDPR
Yeah.
does come on stream, given the existing commercial offerings might not be?
Okay, I think there's two questions there, I think, possibly. One about the GDPR and whether people will opt out. And there were 1 million people already opted out in that first tranche when it was like, whoa, what's happening? So 1 million people have already opted out. After that initial opt-out, I don't think that many more people have. So that's the question about the effect of GDPR and whether the data will be representative or not. The next bit, I think, if talking about the commercial companies that provide the data, I think there's been a review recently, the Goldacre review into electronic health records data, and that has recommended that there are a few trusted research environments, and that should be where the research is done. So I think there will be some direction of travel going forward, and that we will migrate into using different data offerings.
Do we have one from the audience?
Good presentation, thanks for it. If we come up with one commercial question, like we want to know the rare disease in a hospital, will you support this type of commercial research questions?
So the question that you're asking me is, if a commercial company came to us and said, will you do this research,
Yeah.
would we do it?
Oh, well,
that
not
the
really research, we'll be coming to you, say,
Okay, for
can we
intelligence.
have
For
this
intelligence.
set of data? Because it is anonymized to no personal data.
So the short answer is yes. There are restrictions that you cannot do research for tobacco industry companies, and you cannot do it for insurance companies. Okay, and there's probably for CPRD, which is the one that I know most about. They have an approved list of clients and users, so of which the University of Oxford is one. But I think we'd probably have to get more advice on what the commercial entity is asking to be done and whether we can do that. But I think we can.
Yeah, that is
Yeah.
what I want.
Yeah.
Thank you very much.
We've got another remote question here from Alex. Are there any bits of data you'd really like to see recorded more often, e.g. reason, condition, medication prescribed?
Oh, what's on my wish list?
That's a good response.
I think I would like more uniformity of data recorded. And that data harmonization, I think, is a really important step so that we can get closer to the quality of data that you get from bespoke research studies. That's what I would like. I think so. Better coding, consistent coding.
I'll take the gentleman now.
My question is about methodology, I think. You presented some really nice results that you obtained from your research with obviously really useful clinical implications. So my question is, where did those hypotheses come from? Who raised them? And if they came from medical experts, then is there a possibility that there might be unsuspected correlations lurking in the data that we're just not thinking of looking for?
Yep. So you're right. So a lot of the research that we have to do is we have to clearly state the hypothesis that we are testing. I mean, it doesn't have to be hypothesis testing. You can do hypothesis generating, but you still have to set out what your research question is. And I think the way it's going a bit more, a lot of the research funders discourage data mining. They discourage just getting a whole raft of data and going, what does this show us? Because also this data is so vast as well that a lot of associations are statistically significant at the usual levels of significance. So you have to have more stringent levels of significance to be able to, justify it really. So I don't know if I've come to a roundabout way of answering your question, but yes, there will definitely be associations that are hidden, that are unexplored, that we haven't thought of. So if you think of any that you would like exploring, I mean, the other thing we do as well before we do a research question is we review the literature as well to see why this may be a plausible question, and why may there be evidence of an association.
Oh, right.
I was interested in, because I used to work in that, and I know what you referee text, and I know that you miss, Dr. System and so on. Have you explored machine learning to try and decipher text, because it might enhance what you're trying to do? I don't know.
Yeah, I would love to. And we used to be able to get free text, some free text. There were, you'd have to tell our CPRD that you'd like free text around a particular phrase, and you'd say, I'm looking for things about, say, diabetes, and they'd give you the 20 words around it. But then that was all stopped because of anonymity and the GDPR, the other one. So we don't get free text anymore. But I think there is an argument for doing research specifically, looking at free text and ways of processing that using, say, natural language processing to identify themes and codes in it. And I think we probably will be able to do that with particular permission to do that, but it doesn't come in the standard offering. So I couldn't do that tomorrow, but we could, and I think we should, because we're missing out a lot of information. A lot of stuff is in free text because it's recorded for clinical care. So the fact that it's there in real words, it's perfect for clinical care. You go in and your doctor can see you've got that condition because it's there. And really, it doesn't matter whether it's coded or not, but for research where you've only got codes, it does matter.
I'll take one online and then one from the audience.
We've got a question from Ted. I guess it's related to data mining potentially. Do you adjust for known biases in your samples as is done by polling companies?
Short answer, no. No, because much of what we do is we rely on the fact that it is representative of the population from which it's drawn. And there are, you know, the providers of the data have shown that it is broadly representative. I think if we got to the point where it isn't, then we would have to. But at the moment, we don't. I'm sure others do.
Will big data increase lifespan and health span? And what's the role of Corbett clocks, biological epigenetic aging clocks in that?
First question first. Will it increase longevity? I hope so. I mean, I would hope that the research we do, whether it's based on electronic healthcare records or lab science or traditional epi, whatever the research is we're doing, I hope that it would bring benefits and increased health, maybe not just longevity, but living healthily. And, you know, I think one of the tricks that we should do is to look for patterns of people maybe that have a faster decline in health, and see if we can identify what's different about those people who have faster decline, because, you know, one 80-year-old is vastly different to another 80-year-old. And if we could identify patterns that happen earlier in the life course, then there would be potentials to make interventions, and whether that's sort of physical interventions or lifestyle behaviours or medical interventions. So I think it would. Regarding biological clocks and epigenetics, I think that's more a question for the UK Biobank people rather than the routine electronic healthcare records, because we don't have that information.
What are your thoughts in terms of cost benefit? Do you feed in the cost of providing the prescriptions and the treatment? And what are your thoughts on measuring the product benefits of particular treatment? Is that fed into your data?
So it's not really fed into the data. We do health economic evaluations, right, where we use the data to look at the clinical effectiveness of treatments, and then we use the costing structures from other resources, the national tariff, for example, for prescribing costs, and we would look then at the costs associated with that incremental benefit. So yeah, yes, not in everything, but where it's applicable. Yeah,
yes. Yeah, it must be very difficult cost kind of
one related question to that. So do you link your recent episodes to the formulary used?
So there are prescription data, and it has about the drug dosage and the, I can't remember what it's called, but it's like a standardized measure of each drug. And then you have to use a sort of external linkage to the costs data.
Well, the cost data, what we see in NHS, so-called prescription, they are not accurate.
So another
Because
obstacle.
there is something called rebate, which is not really getting reflected in the database.
Yeah, another limitation.
But it's good that you are linking it.
Yeah, we've got a new health economist, Patrick, down there in the glasses. He's just recently joined the team. So ask us in a year's time and he will give you a much fuller answer.
Thank you.
I think we have another one online, do we?
Yeah, we've got another one online from Stephen. Have you seen any anecdotal or otherwise changes over time in terms of the general quality of aggregate clinical research data? And if so, what would explain it?
Quality of data. Well, I think I would say the quality of data is improving, and it has improved. A specific example of where it has improved is particularly in lab test results. So you used to get things that said normal, your blood pressure result is normal. Well, that doesn't really help a lot, because what's normal, you know, if you're anemic, does that mean, if your blood result is normal, does that mean your hemoglobin is at least 12? It could be 14, it could be whatever. So that doesn't happen anymore, because the labs are digitally linked and they actually send down the real results. So not only you won't just get a normal, you'll actually get a reading now of those things. So that data has improved. I think that, I mean, in the flu surveillance platform that used to be much smaller, it was only sort of like 200 practices, they do coding very well, because they it's more like a bespoke study rather than a routinely collected healthcare data. They're encouraged to do really good coding. And I think there are opportunities for improving, but some things have improved, but not everything.
We've got one more bit of input online. It's actually a comment, not a question, a comment. So I'll read it out. So if you want to give me feedback. The GPIT system started when individual GP surgeries started using simple computers in the 80s. And each surgery had their own kit. I understand there are some 4 different systems, each with different coding systems.
Yeah.
Christine has sat in on a presentation by some of the system developers. Not every GP would record data in the Lloyd George records. When coding Lloyd George data, some could not be read. So just a comment on what's happening.
Yeah. So the Lloyd George records were the old paper-based records introduced at the beginning of the health service. And when it migrated into electronic, there was, a lot of it was entered into the summary health record from those paper records. And yeah, some of it would be missing. So generally, when we talk about the data quality, although the data does go back to birth, we say generally from the mid-90s is when the data quality is better. And in fact, CPRD have a flag in their data that says that the data is up to standard, which is an indicator that it's good for research purposes.
I have a question, which is, are there similar activities going on in other countries? And if so, is there work going on to compare healthcare outcomes between countries?
Yes. So other countries do have electronic healthcare records systems. Some are better than others. I think Sweden have got really fantastic ones, and they link through everything, including social care and everything. They have an individual patient. It's not a patient, individual person identifier that all the records are linked. So that's really good. There's in Spain, there's similar health record systems, and there are projects to harmonise the data across different countries so that we can do these collaborative analyses. So yes.
Thanks. Any more?
There is just one question Monica asked earlier. She asked, how can we access data sets? So that's a question for Monica.
Okay, so the short answer is Monica could contact me
Yes.
if she wanted to, but the more general answer is that the University of Oxford is a site license holder for CPRD data. If you're not in the University of Oxford, you can contact CPRD directly, and they will be able to help you out. And basically, my advice would be to look at the websites for all those different resources and contact the nominated contact for doing it. But you need to come with a research question, but we can start that conversation about what the research question is and how to design that study.
So yeah, I'd have a follow-up question on that. So how we ask for your slides that we're able to publish those on our website? So,
I think so. I mean,
we can talk about that.
Yeah.
Well, thank you. I'm just a little conscious that one of the implications of coming back into live meetings is that we have a time limit on the end of the meeting, which doesn't necessarily apply online. And so I think it is probably time now to wrap up. Thank you very much for taking all those questions, and thanks to the people online and in the room for some very interesting questions.
yeah, no, thank you all very much. It's been lovely to be here. Thank you.
So I think once again, I'd like to take the opportunity after all this time to be able to applaud the speaker and thank you very much for the most interesting presentation and the most interesting evening. Thank you very much.